from a series of interviews with users of the DOAC Dipstick.
My name is Felix Schlachetzki. I'm a professor of neurology. My specialty is stroke diagnosis, stroke treatment, with special emphasis in acute stroke, but also stroke rehabilitation. And we are using the DOAC Dipsticks for more than 3 years now with great enthusiasm.
What was your motivation to use the DOAC Dipstick test?
We are in a very exciting time in terms of stroke treatment and stroke diagnosis, and also stroke preventions. And with the new non-vitamin K anticoagulation agents, rivaroxaban, epixaban, edoxaban, and dabigatran, we have additional tools that go beyond to Coumadin or fenfluramine, which is the agent, the drug that we use in Germany. So with that being said, we are having very good stroke prevention strategies in patients with especially atrial fibrillation, but this also causes problems if an acute stroke occurs. And we have to make quick decisions in stroke diagnosis and stroke treatment, because as you know, we still have the time is brain attitude, and that is also applicable to hemorrhagic stroke, to intercerebral bleedings as well. So we have to be very quick. And when DOACs came up with the dipstick, the urine dipstick, as a point of care method to determine whether or not a patient is on oral anticoagulation, we were very excited to get this on board. We don't have the time to wait for the laboratory results to come in when we consider thrombolysis, or in case of a hemorrhagic stroke, also normalization of anticoagulation. So it's a risk-benefit assessment that we have to do within minutes. And the DOAC Dipstick really helps us to gain time, to have more time in this critical phase.
How quickly do you obtain results with the DOAC Dipstick test, also in comparison to lab testing?
In the case of our hospital, we have to send the serum sample to an outside lab, which is just located 5 minutes for transport with a small taxi. But this is the case in almost in any hospital that I know, that the clinical chemistry department is located away from the emergency ward. So it takes time to get the sample there, and then it takes time to get the sample analyzed. And roughly it takes 45 to more than 1 hour to get a result from our lab if we want to have a quantitative assessment. And that is way too long. As you know, in stroke, the number needed to treat to have one positive or one healthy patient again doubles almost in that time. So with the DOAC Dipsticks, okay, we have to get the urine from the patient, but normally this, for our nurses and emergency physicians, this is done within 5 minutes. Then you do the dipstick, you put it into the lab machine, and I think overall it takes, with getting the urine to have a result, about 15, maybe up to 20 minutes. So that's much, much faster.
Can you give us typical case examples of your DOAC Dipstick use?
First of all, I want to remind you that such a DOAC Dipstick, okay, it's critical if you have a patient who is on anticoagulant, but most of the time it's an exclusion criteria. So we benefit the most from the 9 out of 10 patients who don't take anticoagulation. So we are we show that they are not on anticoagulation, and we can do thrombolysis, we can do all the other therapeutic procedures. So it's just like a CT scan where you want to exclude the brain hemorrhage that occurs in 10 to 20%. So we increase our diagnostic confidence in those patients who are not on anticoagulants. I recall a patient who was aphasic, and in real life, the emergency doctor and the emergency personnel, they bring a bag of drugs that they found at the patient's home. There was, in fact, dabigatran. And we're not sure, because it was fairly unused. We're not sure whether or not the patient was taking the drug. So while we transported the patient into the CT and got him ready for CT-CTA, we placed the urine catheter, we got the DOAC Dipstick, and while we had the CT that first of all excluded the brain hemorrhage, then we went to CTA and CT perfusion because it was a wake-up stroke. During that time, in parallel, we got the dipstick, and that was positive. So he was on direct anticoagulation. And so we went directly from there to the angiography suite for thrombectomy and skipped the thrombolysis. And that, in that case, we had parallel workflow with the DOAC Dipstick and the CT diagnostic, and that resulted in a very good and rapid treatment phase, and the patient came off fairly well.
Do you also use the DOAC Dipstick test in other cases than stroke?
We also use the dipstick in any unconscious patient and outside of stroke, encephalitis, where we do have to do, even in a patient with where you suspect severe inflammation or sepsis, where you want to perform a lumbar puncture, then you can exclude the DOAC intake, and then you can easily approach the other diagnostic. So it's do not only think of stroke. There are several other reasons why it's good to know whether or not the patient is on oral anticoagulation.
How do you obtain the urine sample from your stroke patients?
Especially in aphasic patients or patients with altered levels of consciousness, we place a urine catheter for that critical time in the patient's disease, illness, and treatment. And so it's a win-win situation. We do it anyways in these patients where we definitely need it. And if you have a patient with a, say, right hemispheric stroke who's totally capable of giving a urine sample without a catheter, I mean, that's fine as well.
What is the benefit of the test for the doctor, the patients, and for the clinic?
It increases diagnostic confidence in what we do to the patient, and hopefully the patient will benefit from our diagnostic competence. And that's the nice thing about stroke, that you have to integrate a lot of information in a very brief, short amount of time. And the dipstick really helps us in this case. And also for the hospital, we have a benefit, because, I mean, most of the time we don't find the DOAC levels, and that's fine. The DOAC dipstick is much cheaper than a quantitative result that we have. So it also helps us in terms of getting the costs to a reasonable level. Let's put it this way. The hospital saves some money, and it's cozy to have everything that we need for acute stroke care in one room, and that's in the emergency ward and where the dipstick reader is.